So I'd like to introduce our speaker for today, Dr. Raj. Dr. Raj is currently the Division Chief of Pediatric Hematology and Oncology at Norton Children's Hospital, affiliated with the University of Louisville. He has been at our institution for 23 years, and he directs the Advanced Sickle Cell Program. He's done that during the full 23-year period. Dr. Raj completed his medical school at the Postgraduate Institute of Medical Education and Research in Chandigarh, India, and he completed his residency in pediatrics at Stony Brook University and a fellowship in pediatric hematology and oncology at the NIH pediatric branch of the National Cancer Institute. Dr. Raj currently serves as the institutional PI on a HRSA grant related to sickle cell disease and another grant related to transitioning sickle cell disease patients from pediatrics to adult care. So he will be talking to us today about identification and management of sickle cell disease. So welcome, Dr. Raj.
Thank you very much for that kind introduction, Dr. McDonald. So we'll get started here. Is my slide presentation mode clear?
Yes.
Great. So welcome, everyone. It's such a pleasure to talk to you today about a topic very dear to my heart, sickle cell disease. And as was shown in the earlier slides, I have disclosures. I'm in the consulting, I've been a consultant as well as in the Speakers Bureau of 3 companies, Pfizer, Jazz, and US World Meds. So let's get on to the topic. And today's topic, we will first talk about the sickle cell syndromes, which are the most common type of severe hemoglobinopathies we see in the United States. So there are 3 common syndromes that we encountered in our clinical practice: the hemoglobin SS type, which has an incidence of 1 in 375 African-American live births, SC disease in 1 in 835, and sickle beta thalassemia in 1 in 1667. The carrier state for the disorders, for sickle cell trait, it's about 8% of African Americans, hemoglobin C trait in about 3%, and beta thal carrier state in about 1.5%. So the history of sickle cell disease has been known, the disease has been known in Africa for a long, long time. The earliest historical report, you have to go back in the 17th century, in African cultures, they named the illness to describe the sounds of moaning made by the victims of the disease. So, for example, in God tribe of Ghana, there is a peculiar sound, which, as it's noted there, which is really, really very telling that how significantly children with sickle cell disease suffered, early on in those centuries. Now, going back to modern era, we can go back to 1846, where you can see a report in Southern Journal of Pharmacology of case of absence of spleen in a executed runaway slave. Then you can see in the African-American medical literature a case, a disease like sickle cell disease described in 1870. But we are all familiar with the report that was first reported in 1904 and officially published in 1910 by Dr. James Herrick, where he found these peculiar elongated sickle-shaped cells in a dental student, in Chicago. And but it's been over 105-7 years now. We've come a long way since then. So let's look at what progress has been made in the last century. So again, a lot of exciting steps were taken, both in the area of physiology, genetics, and molecular biology. But it wasn't until 1949 when Linus Pauling, he was awarded the Nobel Prize for much of the work, which included work in sickle cell disease. And then the very first disease, which was characterized as a molecular disease, was sickle cell disease. Then we went on to find out more and more information about deoxygenation and how that leads to sickling, and and subsequent pathophysiology of the disease. So sickle cell disease is actually a global disease. When I was a medical student, I was really naive in believing that sickle cell disease only occurred in the United States. But to my surprise, I came to know that there are, while in the United States, we have about 100,000 patients with sickle cell disease. To give you an idea, globally, there are 300,000 newborn born every year with sickle cell disease worldwide. And broadly, sickle cell disease can be categorized into, 4 major categories based on, sequence variations outside the coding region of the gene. So you have, like, for example, the Central African Republic type, you have the Benin, the Senegal, and then the Arab Indian haplotype. So of these, the Central African Republic type is the most severe. And the most mild form is the Arab Indian haplotype. That's partly because of high hemoglobin F levels you'll find in the Arab Indian haplotype. Now, the epidemiology of sickle cell disease, as I mentioned, the sickle cell trait and the disease. But what is important for us to note is the life expectancy. We have made some progress, but really not a whole lot of progress. So as of the last decade, the life expectancies for a male with sickle cell disease was still about 42 years, and females was about 48 years. And the annual cost, this was almost 2 decades ago, was then supposed to be, $475 million for taking care of patients with sickle cell disease in the country. Now, let us look at the actual pathophysiology that happens. So, the very first step that happens in the sickling process is the hemoglobin S polymerization. So normally what happens, there is this point mutation in the beta globin gene at position 6, where glutamic acid is replaced by valine. Now that makes, in the deoxygenated state, when the sickle hemoglobin, the polymers, they sort of stack up against one another and form these rod-like structures which alter the shape of the sickle red cells and give it the characteristic sickle or banana-shaped cells. Now, these cells, because they are misshapen, they also have, as they pass through the capillaries, they undergo hemolysis and they have a shortened lifespan. And when there is hemolysis, there is a lot of mediators that are liberated from the cell, which leads to aggregation of other cells. And this cellular aggregates interacts with the lining cells of the endothelium. And that leads to additional effects like decreased nitric oxide bioavailability, platelet activation, eventually leading to a microvascular obstruction. When I talk to patients, I often tell them, if you think of a tube and put tennis balls in the tube, you see how easily the balls will flow through the tube. But the same tube, if you put bananas in the tube, you will see how, the flow is obstructed. But it is more than just the mechanical obstruction. There's also increased interaction by the sickle red cell and the endothelial cell. So that is a potential target for new therapies in sickle cell disease. So this slide depicts, all other different types of sickle syndromes. So I want to highlight, for example, in hemoglobin SC disease, in SS, I told you when glutamic acid is replaced by valine, you have hemoglobin S. But when in the same position, when glutamic acid is replaced by lysine, you'll get hemoglobin C disease. Now, it's very interesting if you can look at the map of equatorial Africa and also look at the map of sickle cell disease. In the map of equatorial Africa, that's where you have mostly malaria present. You can almost superimpose the two maps on each other. So telling you that patients who had hemoglobin S trait somehow had a survival advantage from malaria. The malarial parasite, especially the falciparum form of malarial parasite, did not thrive very well in the cell which had sickle hemoglobin. Now, patients who had SS disease succumbed to the disease, patient who had hemoglobin AA, they succumbed to malaria, but patients who had hemoglobin S trait or were carriers of sickle cell disease had the survival advantage. So that's how sickle cell disease became very common in this part of the world. So like I said, sickle cell disease is not just a Black disease. It can be seen in a variety of other regions of the world. So I can give you some examples which have accumulated over the years. For example, this is a family in Greece. This is a village in northern Greece where 18% of the patients there have got sickle cell trait. And in this picture, both parents have the trait and both children have SS disease. This is a picture from Sicily, a village of Butera in the mountains of Sicily, where 13% of the patients have sickle cell trait. And both parents in this picture have the trait and the daughter has SS disease. This is a picture from Turkey, a family from Adana in southeast Turkey. Both parents and daughter on the left have SS disease. This picture is from Palestine, Israel, where 3 sisters from a Bedouin family from northern Israel, the lady on the left and 3 children in the front all have SS disease. This is a picture from India where you find this doctor, a very famous doctor called Dr. Sargent, who has committed his entire life for sickle cell disease. When he was visiting India, there is a picture here of a family with the child having sickle cell disease. Now, we have made tremendous progress in the management of sickle cell disease as far as pediatrics is concerned, but still a lot of work has to happen on the adult side. So simple interventions have led to improved longevity in children with sickle cell disease. Now we can say that nearly 95 to 99% of patients are successfully transitioned from pediatrics to adult life. So many of these improvements have happened with simple interventions, for example, with newborn screening, use of penicillin, vaccines, and disease-modifying therapies. So the longer survival has really increased the need to have a very structured and a successful transition program. Sorry. So what has happened over the years in patients with sickle cell disease? As you can see, we are roughly in the early 2000s. We are roughly what I told you about 42 years for males and 45 years for females with sickle cell disease. But in the previous decades, you saw pretty low survival rates, which started to improve in the 70s. A lot of it happened because of improved survival in children. Penicillin prophylaxis came about around 1984, and that one intervention alone led to an 84% reduction in mortality in sickle cell disease. Now, again, more historical timelines here, which tells you all the key time points where we have impacted the course of sickle cell disease. 1980s is when penicillin started, then hydroxyurea was, the initial studies were conducted in adults in the mid 80s to mid 90s, which led to FDA approval first in adults. But believe it or not, hydroxyurea was not approved in children until about 5 to 7 years ago. And then we have made great progress in preventing strokes in children with sickle cell disease. Sorry, this slide I didn't advance. That's what I was trying to say. Now, again, in this slide, you can see that we made great progress in children with sickle cell disease, but a lot of progress needs to be made in the age group beyond pediatrics. In fact, there was a Philadelphia study where they found that after age 18 and by age 30, as high as 10% of young adults can succumb to sickle cell disease. So it's extremely important to have a really organized and a structured transition program to keep the patients within the medical system to prevent early young adult mortality in sickle cell disease. So this is another trend, as you can see that in the 70s, which is shown in gray, and the 90s, which is shown in green, and in the 2000s, which is shown in red, you're seeing the curve moving to the right, and you can see the pediatric mortality curves flattening, which is really a good sign, for at least for as far as pediatrics is concerned, and some improvement for adult sickle cell disease. Now, if you look at another way, which are the phenotypes which do better, as far as hemoglobin SC and S beta plus thalassemia are concerned, their median survival rate has improved to 54.7 years. But for patients with hemoglobin SS, S beta 0 thal, and SD phenotypes, the median survival rate is still below 50. So these are the other common structural hemoglobin variants that we encounter, less commonly in Kentucky, but if you are in other states on either coast, more so in California, you're likely to see a lot of hemoglobin SE disease because that is commonly seen in Southeast Asia, and SD disease, as well as other rare haplostructural variants. Now let us look at the clinical manifestations of sickle cell disease. If you use the mnemonic HBSS pain crisis, you can sort of list all the complications that occur in a patient with sickle cell disease. Now let us look at it in a different way. If you look at patients with acute complications, chronic anemia, and chronic organ damage, you will find you can categorize patients accordingly. Now, this one is like a Venn diagram, and people try to see if there is a particular combination of factors where some patients can experience a constellation of complications more than others. So they try to have like a pulmonary hypertension, hemolysis phenotype versus a vaso-occlusion stroke phenotype, but they found that many patients actually, they don't have that distinct categorization. Many of them fall in between. So there is a lot of overlap of the two phenotypes in sickle cell disease. So we will not be able to cover all the complications of sickle cell disease, but we will address some of the complications today. So let us look at these which I plan to cover today: acute anemic episodes, vaso-occlusive crises, acute chest syndrome. We'll talk about infections and as well as strokes. So acute anemic episodes that happen in sickle cell disease are of three types. You can have either sequestration crises, aplastic crisis, or acute hyperhemolysis. So today I'll be covering the sequestration crisis and aplastic crisis. Acute hyperhemolysis is more, there could be a small percentage of patients who have G6PD deficiency, but the vast majority have actually the more severe sickle cell phenotype. There was actually a publication in New England Journal of Medicine, which sort of categorized patients who can have a severe sickle cell phenotype. And the three things stood out. One is a hemoglobin less than 7, a white count in steady state greater than 15,000, or developing dactylitis before the first birthday. These are the three indicators of a potentially severe sickle cell phenotype later on in life. Now let's talk about sequestration crisis. In this condition, there is acute entrapment of blood in the spleen, which leads to rapid development of anemia. It can even lead to circulatory collapse, and patients could potentially die. So it is very common in children below 5 years of age, but most commonly seen in children between 5 months to 2 years of age in hemoglobin SS disease. But it can occur in later ages in patients with SC or S beta plus thalassemia because they don't undergo autosplenectomy by 5 years of age that patients with hemoglobin SS disease do. And sometimes you can have other symptoms like a febrile illness, but it is important to recognize this condition early, because if you recognize it early, you can immediately intervene. You will have to give transfusion therapy. It is important to keep in mind that once you've had one sequestration crisis, recurrence is quite common. So a lot of times what we do is we put the patient on a transfusion, on a simple transfusion protocol till they're about 2 years of age. And then we do elective splenectomy after they've had all their vaccination series completed. Although there has been some publication now about using hydroxyurea and avoid repeated transfusions and successfully overcoming recurrence of sequestration crisis. Now, keep in mind when a patient presents to the emergency department with severe anemia, we always get a reticulocyte count with at that time. So in a patient with sequestration crisis, you will find actually reticulocytosis. It will be a very high retic count. And these retics, like I said, are much more stickier to the endothelial cells than the red blood cells. And that leads to, blockade of splenic outlet and acute entrapment of blood in the spleen. So one of the ways we have to educate families is to know, for them to be aware of such a complication. So what we do, before I go there, I just wanted to show you the findings on CT scan of a markedly enlarged spleen in a patient with sequestration crisis, and then the pathologic findings of a highly congested spleen, both grossly and microscopically on exam. So how do we prevent sequestration crisis, or how do we educate families about this? So there is a method we use, something called a spleen stick. A spleen stick is not a fancy instrument. It's just a tongue blade. And we place the upper end of the tongue blade at the level of the nipple in the mid-clavicular line. And we put a marking on the tongue blade corresponding to the edge of the spleen. In a small child, it's very easy to, mark it. So the mom has been instructed how to palpate the spleen. And anytime she feels that the marking she's getting today is lower than what has been marked in the clinic, then she's been advised to take the child to the emergency department. So this is a pictorial way of doing it, at the mid clavicular line at the level of the nipple, and you mark it on the tongue blade corresponding to the edge of the spleen. So early recognition is the key for a good outcome for sequestration crisis. Now the next crisis is aplastic crisis. So in this crisis, usually it's related to a viral infection. Parvovirus B19 is the most common. Here you have a markedly decreased reticulocyte count. Now aplastic crisis is not peculiar to only sickle cell disease. It can also happen in other hemolytic anemias, for example, in hereditary spherocytosis as well. The reason being, in patients like myself, for example, who doesn't have any hemolytic disease, if I get parvovirus B19 infection, parvovirus B19, as you know, is an erythrotropic virus. It targets erythroid precursors and shuts off erythropoiesis for about, say, 5 to 10 days. Now, in a person like myself, if I get parvovirus B19 and my erythropoiesis is shut off for 10 days, I may see a drop in hemoglobin, but really nothing happens. I don't have any other symptoms. So after the 10-day mark, there's full recovery. But in patients with sickle cell disease, whose red cell lifespan is not 120 days like myself, but 10 to 20 days, if you shut off erythropoiesis for 10 days, you'll see a dramatic reduction in hemoglobin. And so that is how aplastic crisis can present. And usually, like I said, retics is close to zero. The treatment is again with transfusion, and eventually, once you get antibodies against parvovirus, you are protected for the rest of your life. It's not like a recurrent infection that happens. Now, this is just a deviation here. Parvovirus causes a lot of problems in patients with sickle cell disease other than aplastic crisis. So it can also present with acute bone marrow necrosis. Sometimes patients have severe pain as if they're having a pain crisis. But then in the last 23 years, I've lost 2 patients who have developed parvovirus-related acute bone marrow necrosis. And the result of that was systemic fat embolism. And so I would distinctly remember, at least for the one of the patients, I was making rounds. I'd even finished rounding on the patient on 7 West and was heading to a different patient's room when the nurse called me and said there was an acute change in the neurologic and respiratory status. It happened dramatically for this patient. So the patient ended up going to the PICU, even ended up on ECMO. We did everything possible, but didn't make it. So in fact, in the last 23 years, I've lost 5 patients with sickle cell disease, and 2 of them were due to parvovirus related acute bone marrow necrosis and systemic fat embolism. So just to keep that in mind as in your differential diagnosis of pain crisis, or if a patient suddenly deteriorates in the hospital setting from the neurologic and respiratory point of view. We don't have a vaccine for parvovirus infection. The technology is available, but it's not advanced. But the populations who will benefit from parvovirus vaccine are not that many. That's why we're not seeing much progress in vaccine development. So next is, we talked about hyperhemolysis. So let's continue to vaso-occlusive pain episodes. This is a pictorial representation from a patient's dream, where he's dreaming for healthy red cells, because he's having such severe pain. Pain crisis or acute vaso-occlusive crisis is really the hallmark of sickle cell disease. The pain episodes vary tremendously in frequency and severity. In the cooperative group study, about 5% of patients accounted for 1/3 of hospital days devoted to pain control. The pain in sickle cell disease varies. Patients can develop agonizingly severe pain in as little as 15 minutes. In other instances, the pain can gradually escalate over hours or even days. So the sites of pain varies from each patient. The most common sites occur in the extremities, thorax, abdomen, and back. Pain tends to recur at the same site for a particular person at that particular, in time point. And but the quality of pain crisis is usually somewhat distinguishable from sickle and non-sickle cell causes. So I have had teenage patients tell me that the pain they're experiencing right now is not sickle cell pain. And when we have gotten, for example, an abdominal ultrasound, we have found cholecystitis, or gallbladder obstruction as a cause of pain. So older patients can distinguish sickle pain from non-sickle causes. But keep in mind that patients with sickle cell disease, often present to the emergency department, and that they don't see the providers who have been closely involved in their care in the outpatient setting. They're sort of in a new environment in the emergency department, and they present in 2 ways. There are one group of patients who are writhing in pain, and it's very obvious that they are in pain. The other group of patients are presenting, they handle pain with a lot of poise, and they appear stoic. And those are the patients who run the risk of not being believed by the emergency department staff. But it's extremely important that trust in the patient's what he's saying or she's saying is extremely important in making a decision and a plan for that patient for pain crisis. Remember, there's no pain X-ray test, there's no pain blood test. For example, patient can have as severe of a pain as if he has broken an arm. You'll even get an X-ray. That X-ray will be normal. Similarly, there is no correlation between the number of sickle red cells you will see under the microscope and the severity of pain crisis. So trust in the patient and family's report is key to the management of sickle cell pain. Now, this is again a pictorial representation where a person is feeling that when he was having pain crisis, he was in a box with pins and needles, and when he has relief of pain, he's coming out of the box. So very, very dramatic. Now we have come a long way, in helping patients, and we'll talk about that. So when you have an acute pain episodes, it's important to maintain good hydration and analgesia. We have developed new pain guidelines for the emergency department. I don't have time to go over that in detail, but it's important to promptly administer IV pain medicine. You should also consider using PCA with fentanyl, morphine, or even Dilaudid as needed to get maximum pain control. NSAIDs, like ketorolac, is often used for synergy. Just a caution, just to be judicious about the use of NSAIDs, because excessive use of that can lead to complications like kidney disease, hypertension. And in patients who have pre-existing kidney disease and hypertension, you want to really think twice if you really have to use NSAIDs in the acute setting. Now, again, prevention is avoiding the triggers, and hydroxyurea has clearly made a dramatic change in the frequency and severity of pain episodes in these patients. So this is again a summary of what we talked about. So one thing to remember that when the patient is admitted to the hospital, at least in the first 24 to 48 hours, try to have pain on a fixed dose schedule as opposed to like PRN, because that can, one is, they would have had some relief and suddenly the pain will come on and we have to wait for the resident to write the order. And so that causes a lot of anxiety to the patients. And also sometimes it's wrongly interpreted as patient seeking a lot of pain medicine. So a fixed dose schedule is extremely important the first 24, 48 hours, and then you can decide how you're going to handle the patient. And use of PCA, like I said, should be encouraged in this patient. Also keep in mind to use incentives spirometry in patients admitted to the hospital for pain management with IV opioids. There was a study published in New England Journal, very nice study, where they found patients who used incentive spirometry and those who did not. There was clearly a decreased incidence of developing acute chest syndrome, which is the next complication we'll talk about, in patients who used incentive spirometry compared to those who did not. So it is not uncommon that patient is in the hospital for pain crisis, and about on the second or third day of hospitalization has developed respiratory symptoms, and you get an X-ray and now a complete whiteout of the lung, which was not there at admission. So that can happen. So encourage incentive spirometry when they are admitted to the hospital. So let us look at some special forms of pain syndromes. We talked about dactylitis or hand-foot syndrome, which is very common in infants. Now, infants, if you think about it, they have got a lot of red marrow in their hands and feet, in the fingers and toes. And so they are the ones who get this dactylitis. Now, older children, there's less of red marrow in the fingers and toes. So it's basically an acute bone marrow necrosis that is happening in the digits of these children. That's why they experience dactylitis or hand-foot syndrome. And with older patients, you don't see that. So I mentioned earlier that in the New England Journal study, the children who had dactylitis had 2.6 times more likely to have severe disease compared to who did not have dactylitis before their first birthday. Treatment, you treat them like pain crisis with hydration and analgesics, and it's rare to recur after 3 years of age. Now, these are the consequences of having had dactylitis. So you can see like a shortened middle finger of one hand in this patient. And here you have a shortened second toe in one patient as a consequence of dactylitis. Now, next we'll talk about acute chest syndrome. Acute chest syndrome is now the leading cause of death in sickle cell disease. By definition, it basically is a patient who has a combination of respiratory symptoms, new lung infiltrates, and fever in a background of sickle hemoglobinopathy. So remember, like I said, initial chest X-ray may be normal, but a repeat chest X-ray should be performed if respiratory symptoms are persisting or getting worse. It is second after vaso-occlusive crisis as a leading cause of admission to the hospital, with an average length of stay of about 5.4 days. So why worry about acute chest syndrome? I told you it is the leading cause of mortality. It has got high morbidity. 30% of patients with sickle cell disease will have acute chest syndrome although that is older data. Now with good disease modifying therapies, we have really brought that level down significantly. But once you've had one episode of acute chest syndrome, the recurrence rates are quite high. And recurrent acute chest syndrome has a higher mortality rate, pulmonary fibrosis, pulmonary hypertension, and cor pulmonale. So we have had patients over the years who have developed significant pulmonary hypertension in the background of recurrent acute chest syndrome, and some of them also have had bad asthma also. Combination of this in the background of sickle cell disease is really pretty profound in terms of developing pulmonary hypertension. So remember that a new pulmonary infiltrate is required for a diagnosis of acute chest syndrome. Lower and middle lobes are affected more frequently than upper lobes, and children are more likely to have isolated upper lobe disease compared to adults. You can also have pleural effusions, but they don't necessarily denote an infectious etiology. So infection is the most common cause in children with acute chest syndrome. Bone marrow infarction secondary to pulmonary fat emboli, which I mentioned earlier, is also a reason for acute chest syndrome. You can also get hypoventilation. For example, patients who with sickle cell disease who have undergone anesthesia recently for any kind of procedures, they're at risk for developing acute chest syndrome because of periods of pulmonary hypoventilation. And then there's also a pathophysiologic process called intravascular occlusion. Similar to splenic sequestration, there could be a lung sequestration that could be a cause for acute chest syndrome. So, but most of the episodes are related to infection. So we look for evidence of infection. We get RPP, we get blood cultures, and we also cover for both the common community-acquired pneumonias, including mycoplasma and chlamydia. So we use a combination of ceftriaxone and a macrolide antibiotic, typically azithromycin, for patients with acute chest syndrome. And if there are other viral etiologies, we will, the treatment available for influenza, for example, we will treat accordingly. Fortunately, with COVID, we have had a lot of luck on our side. We did not lose any patient with sickle cell disease to COVID. The nationwide, the mortality, the pediatric mortality of COVID-related sickle cell disease, has been comparable to ours, but however, many adults did die of COVID, during the pandemic. So children did better than adults, like, even patients without sickle cell disease, that was the same story. So, and we talked about fat embolisms. I won't go over that. I'm going to skip that for now. And I also mentioned about the importance of incentive spirometry. Even in patients who have had recent surgery, because 19% of postoperative complications can be acute chest syndrome. And you can prevent that by using aggressive incentive spirometry every 2 hours when awake, for patients who have had recent anesthesia and surgery. So treatment of acute chest syndrome, my simple rule of thumb is that if patient has got respiratory distress, we use oxygen, of course, and then we initiate simple transfusion. But however, if patient is heading towards respiratory failure, then you have to consider even exchange transfusion. We talked about antibiotic therapy, and some patients have ended up on the ventilator. People have tried IV dexamethasone treatment but the studies have not shown a definite benefit of IV steroids in treating acute chest syndrome. Just a caution, if for whatever reason you use steroids in patients with sickle cell disease, whether it's asthma or anything, just keep in mind that you have to taper the steroids. Even in the study that we also participated in, it was a NIH funded study on use of dexamethasone in acute chest syndrome. We found that there was a lot of rebound pain crises, when steroids were stopped. So, but if you do a taper, you can minimize the risk of rebound pain crisis. Sorry, I was talking all along. I missed all these slides. Sorry about that. Now, prevention of acute chest syndrome, we talked about exchange transfusion in a setting of respiratory failure or significant respiratory distress, with a goal to keep the hemoglobin S below 30%. In patients who are to undergo surgery, we want to make sure that they're medically optimized for the procedure. So we put them on IV fluids starting 1 to 2 hours before the anesthesia, and then we monitor them for 23 hours in the hospital to make sure they don't develop acute chest syndrome. Use of good vaccines that we have available now have gone a long way in preventing acute chest syndrome. Of course, penicillin prophylaxis has been really dramatic in reduction of mortality in acute chest syndrome. We have a few patients who are maintained on long-term red cell exchange transfusions, what we call erythrocytophoresis, for recurrent acute chest syndrome, despite being on despite being on hydroxyurea therapy. A brief mention about fever in sickle cell disease. Any patient with sickle cell disease who develops fever, we take it really, really seriously. We have to get them evaluated right away. We want to get a CBC, reticulocyte count, and a blood culture. Now, as far as chest X-ray is concerned, it's a question mark. There is at least one study I know of wherein patients with sickle cell disease who presented to the emergency department with fever, where a diagnosis of pneumonia was made on clinical exam. It was a variety of people who were involved in that study: residents, fellows, attendings. And 50% of the time, pneumonia was missed on clinical exam. So there's more of a tendency for a febrile patient to get chest X-ray when they present to the emergency department. So you treat the patient with antibiotics, like I mentioned, ceftriaxone and macrolide. We admit patients who are less than 12 months of age because of a higher mortality in that age group, patients who have high WBC count, who are allergic to ceftriaxone because we don't have another long-acting antibiotic, and with also, if there's any history of non-adherence to treatment, that's a concern, so we admit those patients. Patients who have had history of pneumococcal sepsis, they're also automatically admitted. And of course, those who are inadequate follow-up, we have to admit them. So if you decide to send somebody home, at least observe for a minimum of 4 hours to just make sure they're still okay and hemodynamically stable, even after you have given them the antibiotics and IV fluids, and arrange a follow-up in the next day. And you can consider a second dose of antibiotic if you have to, a ceftriaxone the next day if you have to, if there's persistent fevers. So let's briefly talk about stroke in sickle cell disease. There clinically evident stroke can occur in about 8 to 10% of the patients. And if you look at incidence, you have about 250 times the incidence of stroke in children compared to those who don't have sickle cell disease. In the Baltimore study, for example, the overall incidence of stroke was 1.3 per 100,000 patient years, but in the sickle cell disease population, it was 285 per 100,000 patient years. Silent brain infarction, but the definition between clinical stroke and silent brain infarction, the difference is that in both situations, there is infarction, but in clinical stroke, you have either a hemiplegia or a cranial nerve palsy or something, but in silent brain infarction or silent stroke, you may not see those obvious clinical deficits, but they are really not silent. They do have other abnormalities, like you should consider working up somebody for silent brain infarction if a child is not, for example, not performing well in school, is having hyperactivity symptoms. Those are subtle symptoms could prompt you to work up for silent brain infarction. After first stroke, the recurrence can be as high as 70% without transfusion. So one of the clear indications for transfusion sickle cell disease is if a patient has stroke, you're committed, that patient is committed to long-term transfusion. Now, you can also prevent further morbidity and mortality by chronic transfusion. So this picture depicts, the incidence of ischemic stroke and hemorrhagic stroke. Most of the strokes in children are infarctive and therefore ischemic nature. But as you can see in the 20s and 30s, the incidence of hemorrhagic strokes does go up. And then later in life, again, the incidence of ischemic stroke increases again. So the risk factors for overt stroke are previous stroke or a transient ischemic attack. Then if patients who've got abnormal transcranial Doppler, we'll talk about that in a minute. And some patients who have had recurrent acute chest syndrome are also at risk for developing strokes. And I also talked about parvovirus B19 infection, which can lead to severe anemia. In a Dallas study, they found that patients who developed severe anemic episodes in the course also had a higher incidence of developing stroke. This one is a normal MRA on the left, but you can see the markedly abnormal MRA in a patient with sickle vasculopathy. So let's look at a couple of cases. In this patient, you have a diffusion weighted imaging with massive left ACA and left MCA infarction with smaller basal ganglia acute infarction on the right, which you see here. And then the other one, this one is day 1, but this one is on day 2, which in addition to the infarcted areas, you're seeing midline shift to the right. And as you can see on the MRA, there is marked occlusion of both the anterior cerebral artery and the left MCA. Case number 2, this is a left MCA distribution infarct with diffusion weighted imaging. The MRA shows clearly absent anterior circulation. The common carotids and external carotids are present, and the vertebrobasilar system is present. So this is a typical workup. In addition to MRI, we also do MRA for patients when you're trying to work up for possible silent brain infarcts or any vasculopathy in sickle cell disease. It's important to use non-contrast studies in patients. Acute management of stroke, you have to obviously, take care of them with oxygen as necessary, have a close evaluation with the NIH-SS scale. Patients can have increased intracranial pressures or seizures. It is important to try to initiate transfusion within 1 hour of presentation. So if the hemoglobin is less than 10, you can just proceed with simple transfusion while making arrangements for getting emergency exchange transfusion. The goal of treatment is to try to reduce the hemoglobin S to less than 30%, but don't forget to give blood as soon as possible. And also avoid CT contrast agents in these patients. So how do we prevent recurrent stroke? So remember, I told you once you have a stroke, you're committed to long-term transfusion. Now, I'll take a moment to talk about the different types of transfusions that we use. We have a simple transfusion where you're just giving packed red cells to a patient, or you can exchange transfusion wherein you actually dilute the hemoglobin S without raising the total hemoglobin. So that is the modality we use at our infusion center. We have had more than 2.5 decades of experience in automated exchange transfusion, what we call erythrocytopheresis. And we have had a lot of experience in this area, and I've been one of the leading centers for a long time. And because we're diluting the hemoglobin S without raising the total hemoglobin, the incidence of iron overload is very low for patients who are maintained on long-term exchange transfusion. And you definitely make an impact on development of second strokes once you place the patient on a long-term transfusion. So, of course, other things to consider if they have got moya on on MRA studies, you have to consider revascularization surgery with our wonderful neurosurgeons help us out. And with moyamoya disease, you also have to place the patient on long-term aspirin. So can we first prevent the first stroke in sickle cell disease, what is called primary prevention? There was a study done by the NIH. It was called the STOP study. STOP stands for Stroke Prevention Trial. In this study, what they did was they did used a technology called transcranial Doppler ultrasound. They looked at the velocities in the middle cerebral artery. And so they categorized patients into 3 groups. Normal velocity when it was less than 170 centimeters per second. Conditional when it was 170 to 199, and high velocity if it was 200 or greater. So what they found was they initiated treatment based on these findings. How did they actually do the trial? They first, one group of patients who had high velocities, they were just given standard of care, no transfusion. But the second group of patients were placed on transfusion, on monthly transfusion. And the outcome was the patient who received regular monthly transfusion, only 1 out of 63 developed stroke. But in the non-transfused arm, 11 patients went on to develop stroke out of 67 in that group. So the NIH had to put a stop to the study. And based on these results, they said, patients who have TCD velocities greater than 200 centimeters per second are at high risk of developing stroke, and they have to be maintained on chronic transfusion. So such patients here, we place them on long-term erythrocytopharesis. If they are a little bit older, 3 years or above. If they're younger than 3, we keep them on simple transfusion till such time that they can have a vortex port placed on chronic transfusion. So this is a dramatic change in the management of sickle cell disease, which has impacted clearly the morbidity and mortality for patients. Next, again, this is furthermore evidence about the impact of transcranial Doppler velocity monitoring. As you can see, in the state of California, the stroke rate dramatically declined after patients who were at high risk for stroke were placed on chronic transfusion protocols. Now, there was another study that NIH did. It was called STOP2 study. They said those patients who have been on transfusion for, say, 30 months, for example, can we actually stop the transfusions and see what happens to the patients? Because many centers did not have the technology of erythrocytopharesis available to them. So they were getting worried about patients developing iron overload. But unfortunately, that study had to be stopped also in the middle, because in the patients in whom transfusion was stopped, even though the TCD velocities had normalized when they were on transfusion therapy, after stopping transfusion, 2 patients developed stroke and 14 patients developed abnormal transcranial Doppler velocity. So again, further evidence that patients with increased TCD, you cannot just stop transfusion. So then, this is again a more a graphical representation of the findings I just mentioned. Then they also tried, let us see what happens to patients who have developed stroke now. Can we switch them from chronic transfusion to hydroxyurea and phlebotomy, what we call the switch trial? Even this trial failed, but because patients who were switched from chronic transfusion, these were stroke patients, when they were switched from transfusion to hydroxyurea and phlebotomy, 7 patients went on to have strokes, but there was no difference in iron overloading in those patients. So again, in patients with a stroke diagnosis, switching to hydroxyurea is not done. Then there was another study called a TWITCH study, where they looked at changing patients who are having high transcranial Doppler velocities, whether we can switch to hydroxyurea. And they found that in this category of patients where they did not have stroke, but only elevated transcranial Doppler velocities, one could successfully switch patients from a transfusion protocol to long-term hydroxyurea. So this was possible in the TWITCH study. So some of our patients can come off transfusion if they are just having increased transcranial Doppler velocities. And but the clear, we have to be convinced that patients are going to be adherent to hydroxyurea therapy, which can be a problem in some patients with sickle cell disease. I'm suddenly realizing that we're up to 12:55 and I have so much more to cover. So I don't think I'll be able to cover all that, but I want to leave a few minutes for questions and go quickly to my last slide here. And just tell you, leave you alone. I mean, even to talk about the new therapies and the existing therapy in sickle cell disease, a lot of time is needed. 1 hour doesn't do justice. But I want to tell you that Sir William Osler once said, a person who knows syphilis knows medicine. But today I would say a person who knows sickle cell disease knows medicine. So I encourage all of you to enhance your knowledge about sickle cell disease, the most fascinating disease you will encounter. There's so much in there, exciting genetics, biochemistry, physiology, epidemiology, sociology, all these ologies, and a lot of things that if you have interest in the physician clinician in us, there is plenty of science, academia, mentoring, advocacy, activism, equity, a lot of exciting things you can do in this field. So this is
Thanks,
an
Dr.
area.
Raj.
Yeah, thank you again.
That was
Appreciate
excellent.
it.